AI and telemedicine. You all see any big impact coming from either one of those?
It's going to be the biggest impact in healthcare over the next 2 to 5 years.
This is Real State, a podcast from CSG South. Join us as we talk with policymakers and public leaders shaping state-level decisions across the South and explore how ideas move from policy to real impact.
Welcome to Real State. I'm your host, Lindsay Gray. For this special episode, we're taking you inside this year's Southern Legislative Conference in Lexington, Kentucky. State leaders from across the South gathered to tackle one of the most pressing issues facing every legislature, Medicaid. Healthcare is one of the largest investments in every state budget, and today's policy decisions will have lasting impacts on the access of care, rural communities, workforce development, and state finances. During this plenary luncheon, Kentucky Senate President Robert Stivers moderates a thoughtful discussion with legislators and healthcare leaders about the evolving Medicaid landscape, including federal policy changes, workforce shortages, rural health care, artificial intelligence, telehealth, and strategies for building a more sustainable healthcare system. Whether you're a legislator, legislative staff member, or simply interested in how states are navigating these complex challenges, stay tuned. This conversation offers valuable insights from leaders working on these issues every day. Here's the plenary luncheon recorded live at the 2026 Southern Legislative Conference in Lexington, Kentucky.
Ladies and gentlemen, good afternoon. Welcome to this policy session during our plenary luncheon. We're glad everyone has shown up, quite the crowd. This session will bring several leaders from across the southern states to talk about the policies, workforce participation strategies, program sustainability, and the fiscal aspects of access to care. We're fortunate to have several people with us today. I'm going to introduce our guest here today. First panelist to the far right is Senator Jim Burgin of North Carolina. Senator Burgin is a fourth-term state senator from District 12. He chairs the Senate Health Care Committee, the Appropriations Committee on Health and Human Services, co-chairs the Joint Legislative Oversight Committee on Health and Human Services. He also serves on the Agriculture, Energy and Environment, Finance, State and Local Government, and Pension, Retirement, and Aging Committees. He is also one of our vice chairs for the CSG South Human Services Public Safety Policy Committee. Our next panelist is Senator Kay Kirkpatrick of Georgia. She is closest to me. She represents District 32. She is a doctor, has served in the Georgia Senate and legislature for 9 years. She currently serves as the chair as the Senate Children's and Families Committee, vice chair of the Health and Human Services Committee, and serves on the Insurance, Labor, Appropriations, Government Oversight, and Military and Veterans Committees. She also serves on Georgia's Joint Defense Commission and Behavioral Health Coordinating Council. Our next panelist, who is second from my left, is Representative Ashley Hudson of Arkansas. Representative Hudson represents the 75th District in West Little Rock, and she has done so since 2020. She serves on the Judiciary Committee, the City, County, and Local Affairs Committee, the Joint Budget Committee, and is vice chair of the Courts and Civil Law Committee. She has been selected multiple times by both the Arkansas Judicial Council and the Pulaski County Bar as their legislator of the year. And our final panelist in the middle of the group is Jeb Duke of Humana, Inc. Jeb is the Senior Vice President of Medicaid Markets at Humana, leading the healthcare company, and in his role, he is responsible for Humana's Medicaid health plans for market operations, strategy, clinical programs, external relationships, and plan performance. Jeb has 18 years of experience in the healthcare industry and has served as the chairman of Kentucky's Association of Healthcare Plans and is a board member of the Kentucky State Chamber of Commerce. I'm going to go back and just reiterate one thing real quick. I think all of us know that in our budgets, and I know in the state of Kentucky, our populations are changing for that which we deal with in Medicaid. It becomes really quite complex since a lot of the things we are reactionary to, not based on policies we adopt, but that which comes down from the federal level. And it tends to change with administrations, which sometimes make it difficult when you want to do some long-term planning. In the 30 years I have been in the legislative process, I don't think there is anything any more complex or anything that takes more thought in our budgetary process in dealing with Medicaid and our contribution rates, as well as what we will define as the population for which we serve. So I'm going to start off with a lot of questions, and hopefully at the end we'll be able possibly to answer some questions or take some questions from the audience. And the first one, I'm going to go and send it to you, Jeb. You get it. Give us your overview of the current Medicaid landscape as it relates to federal policies, the developments in the states, what we should be watching for, and what things are influencing the state Medicaid planning and decision-making as you see them.
I wanted to start by just thanking Senator Stivers for the opportunity to speak today. If you haven't met Senator Stivers, he's an asset for our community. He's just as welcome in our rural communities as well as our metro communities. I don't know if you're going to talk about gas policy and prices, but if we can bring down gas prices, Senator Stivers probably would be the biggest winner from an economic return. I also want to welcome everyone to Kentucky. I'm a Kentuckian. My parents were born here. I plan to live my life here. You're gonna spend a lot of time, and we're gonna talk about horses. You're gonna talk about bourbon, but I also want you to recognize Kentucky is a place of business, especially as we talk about healthcare. Our nation's largest hospitals, our nation's largest nursing home facilities, our nation's largest home health companies, where our nurses are trained at the largest level in America. Also, our Medicare Advantage and our fastest growing Medicaid company is all happened in Kentucky by Kentuckians, and it really speaks to what the South can do and what people can do in this community. So please, as you're exploring Kentucky, also explore our businesses. If we talk about the landscape of Medicaid, 1 in 2 births in America are born with Medicaid reimbursement. In Kentucky, 1 in 3 Kentuckians are on Medicaid. We are really living in a time where things are changing. And I like to think about 3 different things. I think you all might have talked a little bit about it this morning, but one is just the cost. We're going to have fiscal constraints as we think about state budgets and Medicaid, and how we handle that at the state level with our provider partners within Medicaid. COVID and the PHE, those are in our rearview mirror. We have to deal with lower reimbursement, also maintaining access and ensuring that healthcare is delivered at that same high level that Americans expect. I think second, I like to think about what are the impacts of H.R. 1? What is the big, beautiful bill, and what are the impacts? How are we going over the next several years roll this program out and make sure it's successful? That means in some states where we haven't had cost share in Medicaid. It means in some states where we've done annual re-verification of Medicaid eligibility, doing it biannually, and what that creates in the churn and the reimbursement for providers. And frankly, it means work requirements, right? How are we going to work together to ensure that we're educated patients, we've educated members, and people who deserve and have the right to have health care are getting that right information and completing those requirements? And how are we meeting the intent of the policies so that we can ensure the results are yielded from it? I think the third thing I think this was discussed this morning, but rural health is absolutely something we should be sitting and thinking about in every state. What are the workforce challenges that these communities face? How do we support them in those challenges? And as we're thinking about HR 1 and we're thinking about the potential impact of our rural hospitals and those providers, how do we support them through this time to ensure that that access is not lost and those communities don't feel that harsh economic impact? So those are the three things I'm thinking about really as we think about national policy at the state level.
Okay, then let me open this up to our three policy makers. You have to live with the policy we adopt or that comes from the federal government. I'm going to open it up. We'll let either one of you all start. But what are the most difficult or pressing policy issues as it relates to implementing or budgetary impacts that either in North Carolina, Arkansas, or Georgia that you all are dealing with? Who wants to start?
I'll go.
Go ahead, Doc.
Okay, and I'm from Kentucky, by the way, so I'm so happy to be home. I wanted to say that Georgia's in a little bit different situation than a lot of other states because we already have work requirements. And so the implementation of HR 1 is going to actually add people to our roles, whereas another state, people are going to peel off of the roles. And that's because we already had coverage for caregivers up to age 6. The bill takes it up to age 14. And then the other thing is it adds the medically fragile population, and the definitions of that are not clear in the federal law. So we're going to have to figure that out at the state level, and that's going to come down to which ICD-9 codes or 10 codes are covered. I'm showing my age, ICD-9. But which codes are covered and which things need to be case by case and which things are going to be automatic based on the diagnosis. The other thing, and this is a budgetary thing that is not really related to HR 1, but I just want to mention it so it gets on the radar, is pharmacy costs and the increase in GLP-1s in particular. I read this week that 15% of the population is on GLP-1s, and what to cover and what not to cover in Medicaid is we're already dealing with that as a challenge in our state.
Senator Burgin?
Well, we just passed our budget last week. We were the last state in the country to do that, and so we did that. And we had to budget about $1.1 billion for our Medicaid rebates. So it's very concerning. And when we started looking at cost factors, the ABA services, the services for autistic children, is through the roof. We have 250% increase in the number of people getting services. But then when we look at individual providers, we've had much in the last 3 years as a 900% increase. We have people that are telling folks to take their children out of school and put them in 40 hours of services. And we just, in the last week when we passed the budget, we put a cap on the number of providers that can come into the state. I think we need to put some other caps in force. We have right now, through Medicaid expansion, which we did 2 years ago, we had about 780,000 added to Medicaid. And that 90%, we covered the 10% that the state was supposed to pay through tax on the hospitals. And then we also put in the bill that if any of that changed, if the 10% changed, or if there was work requirements required and we didn't meet that we would suspend the expansion population. But as the federal government is working on all these things, we still don't have all the rules. And I'm a rules guy, so I like to know what the rules are going to be, so we know how to handle all of these things. And we've got costs coming down. We're one of the few states that still all of the determinations are made in the county level. So we have 100 counties in North Carolina. And you can imagine 100 different counties doing things. Your error rates are all over the board. And then the administrative cost to our counties is going to be $69 million. And that goes into effect this October. So you can imagine they're all calling saying, are you going to make us whole or not? And right now we have not done that. So there's just a wealth of different opportunities for us to deal with Medicaid. But folks, it's not getting better. And we went to managed care. We went to managed care the first year I was in office, and that was supposed to level out everything and keep the costs down. And then, like I said, this last year, the biggest rebates we've ever had in our state happened under managed care.
Representative Hudson, thoughts from Arkansas?
Yeah, I think that what I'm hearing from all of the other senators and representatives up here is that all of our states really benefit from systems that have predictability, which we don't really have right now. I think over the past few years, we've seen a lot of unpredictable ups and downs within the Medicaid system, and that's something that really, to some extent, we can't control. Because a lot of our marching orders about how to administer these programs come from the federal level. And so we're left, as my colleagues up here to discuss, to try to figure out what rules might be needed in order to implement new programs in our states, and how to interpret legislation that may not necessarily make sense with what our existing state level legislation tells us we're supposed to be doing. So our administrators of our Medicaid programs are dealing with some really unprecedented challenges from that respect. The other problem that we're running into in Arkansas is this idea, and I know we're going to talk about it more later, of not only recruiting, but also maintaining a healthcare workforce. And we have been working on different programs and measures over the past few years to try to improve our workforce. But the reality is, as we try to come up with different and creative approaches, we're all working with a finite number of dollars. We're all working with a finite number of people who can come in and provide these services. And we're especially dealing with challenges in our rural areas because of other issues that we may have with infrastructure, with education, that make it hard to attract providers to come into those areas, especially in situations like we have in Arkansas, where a number of our rural hospitals have been closing. So from the Arkansas perspective, we do look at this large Medicaid population that we're trying to provide care for, shrinking workforce in some of these areas of healthcare that are needed, and the added challenge of having these hospital closures in rural areas. And so, just to kind of set the table, I think that those are challenges that everyone in this room can identify with in their states. A lot of southern states are dealing with these same issues. And our challenge as state legislators is to try to distill these mandates that come from the feds and put them into some sort of policy so that we can tackle those. And that's sort of, I think, where we're all sitting at this point.
Senator Burgin, you talk about this, and this is, I think, for all of us, significant healthcare changes that we see coming down the line or have already come down the line. But do you have any thoughts about what legislators at the state level should look for? Something you would say, hey, we looked at this and we could do it better, or maybe we don't even need to do it at all. Lessons learned from what you all done.
We've all got to be better about forcing folks to give us good data. I'm a data-driven guy, and our treasurer, I got this from him, but he got it from somebody else. In God we trust, everybody else send me data. And so I think that's what we ought to do. We ought to tell folks, we need your data, and we need to see. We need to be comparing costs. A group of us were talking this morning about scope of practice, and we were talking about advanced practice nurses, but then there was a study done that shows, I think somebody's going to maybe talk about it, a study done that shows that the advanced practice nurses, sometimes they even order more tests, and so the cost of going to maybe an advanced practice versus going to a primary care doc could be higher. We need to know that, and it's just like I told folks about the ABA services. That happened over a 3-year period. And so we didn't catch it, though, until the second year and didn't act on it till the third year. So it's cost, close to $2 billion that we should have had some kind of governor on so that we, kind of held that down. So I'm talking to DHHS now about a report where anytime a level of service moves more than a certain percent, that it sets off an alarm. So we start looking at it early.
Then I'm going to go to you, Senator Kirkpatrick. You're a doctor, UK, U of L. Appreciate that. House divided. Some of us on this podium are the same way. Me. But we've heard $2 billion. So in Georgia, what do you all look at to determine whether it be $1 or $2 billion that you're getting your ROI, you're getting your money's worth for your investment?
Well, to start with, and this is true in every state, Medicaid's our second biggest budget item in our whole thing, K-12 education being number one. It's a massive amount of money. So between the two of those things, it's 77% of our budget, and I'm sure it's very similar in other states. a lot of that is programmatic. It is already fixed based on the FMAP with the federal government. And so when enrollment goes up or down, there are these wild swings in our budget that can be hundreds of millions of dollars. And that's very hard to predict. So that's problematic. The other thing is we do have a managed care model in Georgia, and I won't get too far into that except to say that in the legislature, we like to increase provider rates, particularly for providers that haven't had an increase in a long time. And we know that only 60% of our physicians participate fully in Medicaid. And in order to get more people participating in the program, we need to raise those rates. Unfortunately, some of our managed care companies, not all of them, have then decreased rates on their own, and the accountability for that is not quite where it needs to be, so we're working on that. But from the ROI standpoint, the data, a lot of our programs are outsourced. The management is outsourced, and getting the data back from the vendors, we can get it, but it may not sync with our budget cycle. And so the data is a huge challenge, but I agree, that's what we've got to operate on.
Okay, then let me throw this out. We all think we have really good ideas when we pass legislation, certain sense of pride and authorship. But then once you actually pass it, it's kind of like, uh-oh, maybe we shouldn't have done that. Or, wait a minute, this that we did actually performed better than we thought. So, Representative Hudson, what do you got? The good things, the bad things, the things you wish you did do, or the things you wish you did more of?
You know, and I think, and Jeb could probably speak to this, I mean, because, you know, his company has to live with some of the things that we do, right? What we always have to try to keep an eye on is the purpose and the reason that we pass legislation. And what we forget often as legislators is all of the rulemaking and all of the effort that has to happen after we pass legislation, and leaves the providers, the insurers, and the beneficiaries to try to figure out exactly what it means, what these changes to the law mean, and how they affect them. And especially when you're talking about providers, how that affects them in their practice, whether they can continue to practice, for example, or whether they need to change how they're coding for billing purposes, whether they need to get new providers in different specialties in order to continue to provide a service. And so, you know, I think that most recently, we've had sort of a micro and a macro example of this. On a micro scale, I ran legislation and passed legislation last year to have Medicaid coverage for lactation consultants, which Arkansas didn't have. And in theory, this is a good thing. It is a good thing. I don't think that it's even in theory. I think practically it is. However, there's a lot that goes on behind the scenes after we say, now we're going to cover lactation consultants. There are different types of lactation consultants. There are different certifications for lactation consultants. There are different billing levels for the types of services that you're providing. And once we pass this legislation, we pass it off to our Medicaid administrators and we say, good luck, y'all figure it out, right? And that's just one service line that we passed in one session. And so that rulemaking is continuing now. And that doesn't even take into consideration some of the pushback that we often get from in a Medicaid expansion state, for example, from some of the insurers that provide the Medicaid expansion coverage, and whether they want to add this into their service line or whether they, you know, depress the rates in such a way that makes that coverage illusory. On a macro scale, we can look at the Healthy Moms and Healthy Babies Act, which we passed in the 2025 session, which is a larger, all-encompassing maternal health bill that covers a lot of different types of service lines and tries to tackle our maternal health crisis through a bunch of different programs, care coordination, investment in telehealth and in rural health and our providers in order to take a multi-pronged approach to a very big problem. So take what I just said about the lactation consultants and take that times about 1 million. And that's what our Medicaid administrators is trying to deal with now, trying to figure out how we implement this big, incredible, amazing project in a way that actually delivers services in a way that improves women and infants' lives. And when you're talking about transformative legislation like that, to us, like, we pass it, we all high five, there's a photo opportunity, and then we go home. But the work continues for the providers and the beneficiaries and the care coordinators and the insurers that we've now given this mandate to. And I think we often lose track of that when we pass this legislation, there is a real tangible, practical effect on the people who live and breathe and work in this industry every day. And we need to remember that as we're putting together and crafting pieces of legislation, whether it's going to be transformative and help our constituents or not, but really what that day-to-day is going to look like. And never forget that every time we write a piece of legislation and submit it for passage, that there are real life implications to what we've done.
So I want to throw it open to the two Senate members. That oops moment or that aha moment that, hey, we did something really good, or we didn't do what we thought we did, or we should have done more of it.
Medicaid expansion, I think we were the last state to do it, and there was a lot of controversy over the years, and a lot of folks were very concerned politically about it, and it turned out that it was not that at all. I was always against expansion because I thought it was just going to run cost up, but when we actually made the arrangement with the government, we got $1.7 billion of new money, plus we got $4 billion for our hospitals, and then the HAS money that follows. And so, I mean, it ended up being $7 billion of new money coming into the state, and I felt like we had a fiduciary responsibility to do it. I'm a big proponent of mental health. I think that we don't concentrate enough on mental health, and the prior secretary and I traveled the state doing town halls about mental health right after I came into office. And what we were able to do, we took $835 million of that bonus and designated it toward mental health to build new mental health hospitals and new facilities and put practices out in rural North Carolina. And I don't know if we're going to get into talking about the rural transformation money, but we're getting an additional $213 million starting this year, next year, and for 5 years. Every state in here is getting money. And we need to be real careful about how we spend that money and to make sure that we really do invest it in rural health. I was actually in Las Vegas the week it was announced at the Consumer Electronics Show, talking about artificial intelligence in healthcare and looking at healthcare and innovation. And while I was out there, I had a request, and it was announced while I was out there. Before I left there to come back, I'd had requests for $150 million of funding. I told folks I was asked to fund things I didn't even know I had a problem with. So, there's a lot of money, and I described it as we have newly stocked ponds and everybody wants to fish in them. So if you're from the country, you know what I'm talking about. There's going to be a lot of people with a lot of solutions for problems for all of this money that we're going to be getting.
Senator Kirkpatrick.
Yeah, so we took a little bit different approach in Georgia. We've kind of chipped away at Medicaid, and so pretty much everybody's covered except for the able-bodied 18 to 64-year-old population. And so we passed a bill called the Patients First Act, which was a few years ago, and the idea was to have in-sync programs. One is for the population I'm talking about that had the work requirements, which also included educational, volunteer, caregiving opportunities and things like that. And then another program, that was called Pathways, and then another one called Access, which had to do with a state-based exchange, which the idea would be to get people onto insurance that actually would be accepted in a doctor's office, because a Medicaid card doesn't necessarily get you seen in a doctor's office. And so that was a good idea, and what we found out in the implementation was that the Access program, the exchange-based program, was very successful. 1.5 million people signed up for that. The other program, the Pathways program, got off to a very slow start, and you can't just put something on a website and expect people to figure it out in the rural areas. And so what we learned is that we needed right out of the gate to be reaching out in communities and telling people what they needed to know to participate in this program. I do not think we did a good job with the rollout, and we now are backfill some of that, and the participation has increased. But we do that a lot in state government. We have great programs that we pass into law, and we fund them, and then we don't tell anybody. So I think the disconnect between us and the public sometimes is large.
Okay, Jeb, I'm going to deviate from my notes a little bit.
Oh,
Right.
It says I'm not to ask you who the winners and losers are in here. But what I am going to ask you are not the losers, but identify states, and they may not be southern states, that have, from your perspective, and there's always give and take between the Medicaid managed care groups and the legislative and the providers and everything else. But tell us some of the states that have done this well, in your opinion. And why have they done it well?
Before this, we were talking about working in an ecosystem. Everything we decide from a policy has a different impact on a provider or a product. We were talking about exchanges. Our exchange policy absolutely impacts Medicaid, and our Medicaid policies impact the providers, and the provider impacts impact the community. I think we need to take that same observation and think about how we develop policy. We need to understand that our policy is working in a framework of CMS under a federally mandated program. And when we're thinking about it, we have to understand what are the waiver implications, what are the approval process, especially as CMS is stepping back and saying, how do we create more consistency in Medicaid over time? So what I encourage and what I've observed are states that think about a process, understanding community engagement, stakeholder engagement, understanding impacts, developing policy, and after the policy is created, it's having the runway for a good execution. So they're going out and they're doing the planning, they're creating the time so they're effective upon launch. I'm going to pick a state from the South, absolutely. I think Florida did a good job. So if we look back to 2011, that's when they decided they're going to go statewide managed care, but they looked forward to 2013 and 2014 for a rollout. So they did the policy development, then they ran the procurement, and then they went out and made sure they understood the impact before the planning. And then they executed on a rollout basis over time so that there wasn't significant change that wasn't aware within the community and all the impacts in that ecosystem. And it was relatively effective in ensuring that they did that transition to fee-for-service to managed care.
We've already touched on this, and you all know we are going to come back to it. In Kentucky, we had quite the large debate this year about unserved or underserved area, which gets into workforce. It's been mentioned to be more rural, but in our largest city, Louisville, Kentucky, the metropolitan area of over 1 million people, we have unserved or underserved areas. In my home area, Eastern Kentucky, there are areas that are unserved or underserved areas. What is the solution to that? University of Kentucky, we have data, trying to verify this, that 60% of the doctors that graduate from the University of Kentucky leave the state. The lack of nurses, the lack of telecommunications and telenetworks. So we're going to start far in and work our way around. Talk about workforce shortages, delivery of healthcare, Senator Burgin.
Thank you. North Carolina is the second most rural state behind Texas. I know that sounds interesting, but it is. And what we discovered, 77% of all the doctors now work for institutions. And we've already predicted that we're going to have a 22,000 nurse shortage by 2030. So we've been working, we have 58 community colleges, one of the most robust community college systems in the country. And so we're working with our community colleges, with UNC and other organizations to double the number of nurses that we're turning out. We're also opening some new medical schools. Another one's coming online this year, and then there's another one planned. But we've got to not only produce the doctors, we've got to entice them to go to rural North Carolina. So a couple of years ago, I introduced a bill to pay their debt, $100,000 toward their debt if they go to one of our rural counties. I wanted it to go to 200,000 this year. It's going to go to 150,000 this year. Most of the folks that are coming out of medical school right now are coming out with debt up to $400,000. And they just can't, I was talking to a lady here earlier today, and I don't know where she's at, but her husband, she said this publicly so I can repeat it. They've been in practice a long time. Her husband's a doc, and they just paid off his student loan, for years and years and years of work. That shouldn't be the case. We need to make sure that we get people engaged in medicine. We're trying to identify kids as young as in high school that want to become doctors, and then try to help them follow that path, get them through school, get them into rural North Carolina if they want to go. And then the other thing I'm pushing, and we haven't gotten it done yet, is to raise the rates for our rural doctors, our rural primary care doctors. I want to pay them 110% of Medicare, not Medicaid, to entice them to stay independent and to stay in rural areas. And then I said this earlier, I jokingly also say I'm going to introduce legislation to set up a matchmaking company to get them married to a local person in rural North Carolina so they'll stay there.
There are people in Kentucky who've thought about that. Arranged marriages.
Yeah. Medical marriage.
Yeah, arranged marriages. Once you get them rooted there, it's hard for them to leave. Senator Kirkpatrick, you're a doctor. You may have a totally different perspective.
Actually, I think the thing that we have realized is that we're competing with all of y'all, and we're competing with the whole country. And so what we've got to do is grow our own, because there aren't enough people in the whole country for health care. And so we've got to start earlier, which I don't think we have really done as much with that as you have in North Carolina. But we're focusing more, not just on medical school, but on graduate medical education, meaning residencies, because we know that that greatly increases the percentage of people that will stay in an area where they train. We haven't even gotten to fellowships yet, but we're trying to get our state government to understand that we can leverage federal money, Medicaid money for GME. And some states are doing a better job with that, and we need to take full advantage of that. The other thing is we need to continue to work with our hospital partners to understand that residents, and I was one a long time ago, are basically free labor. And they're a lot less expensive than paying nurses overtime to run things to the lab or start an IV or whatever. So we're trying to work in partnership with our hospitals to create more residency opportunities. And we've done a good job with it. The problem is, just like all of your states, we're growing. Southern states are growing. That's not true around the country. But even though we've added a lot of providers, a lot of physicians, a lot of nurses, a lot of programs, we can't keep up. And that growth is not going to stop. I predict we're going to see more of that. And so we've got to start earlier and create more programs so that we can train people in our states and keep them there.
Representative Hudson, I think you were the first to bring up rural health care. Thoughts in Arkansas?
There are two issues here, right? We need to not only attract new providers, but we need to retain the ones that we have. In Arkansas, we have taken steps over the past several years to try to loosen up some of the regulatory hurdles to independent practice for APRNs. And we've tried to provide grants and reimbursement for student loans for providers who will stay in the state or who will work in rural areas for a period of time and commit to doing that work in our rural communities. But those are all great things to help us to attract new providers. But I'll tell you something. I was looking at the match day post that UAMS, our largest teaching hospital in the state, did recently. And what I noticed was that most of the medical students who were graduating from the University of Arkansas and practicing in areas like primary care, pediatrics, some of those bread and butter areas that we desperately need more professionals for, they were all matching out of state. They were leaving the state of Arkansas, and we were really not retaining very many of our own healthcare professionals. And I think that we have to take a hard look as Southern states as to the why behind that. And I think that there are several, obviously there are several different factors. If any of us had figured out all the factors, we'd be in a much better position. One of them, of course, is the flip side of this, which is with the closures of rural hospitals that we continuously see in Arkansas. And we have seen several more make announcements over the past year that they're closing either the entire hospital or various departments. That doesn't give a lot of that predictability I mentioned in my first response to graduating medical students and nursing students if they don't trust that they're going to have a job in their local community when they get out of school. And we have to do more to stabilize our rural hospitals. And when we talk about Medicaid cuts coming from the federal level or adding workforce requirements without thinking through exactly how that's going to affect our rural hospitals, we're also taking a bite out of our potential workforce, right? If rural hospitals are dealing more with uncompensated care, if they're dealing with more ER visits, and those razor-thin margins are dropped even lower and they get into the red, then we have an issue with maintaining our workforce in those rural areas. So whenever we enact these policies, we have to be thinking ahead, as Jeb was talking about in the case of Florida, 5, 10, 15 years ahead as to how these policies are going to affect our systems. And that's the other big thing that I think that all of us need to remember when we're talking about healthcare policy generally, is that when we talk about a healthcare policy and we talk about attracting providers, we talk about retaining providers, we talk about our rural hospitals and having access to care, that's not just a healthcare question. This is a systemic question, right? A provider wants to move into a community where their kids can go to good schools, where there's infrastructure in place, where their spouse can get a job if they want to. They want to know that they're in a safe community. They want to know that there are activities for their kids to do on weekends. They want to know that there are cultural opportunities and all of these different things in their community. And if we are trying to attract them to go into areas where we haven't made that investment into these other areas of community in our state, then we're going to continuously be asking the question of how do we attract new providers, because we're not going to retain the ones that we have. They're going to continuously be going into these communities, staying just long enough to get the benefits of these programs that we've offered them, and then getting out as quickly as they can. And so when we're talking about healthcare policy, we really need to be taking a broader look at how the other policies in our states are affecting the ability to retain our healthcare providers and to encourage them to be parts of those communities that we desperately need them working in.
Jeb, you've heard this, and I'm going to come back to this in essence from your perspective. Lack of a developed workforce, lack of health care. Most recently, there was an area that we may be as simplistic as losing the OBGYN, and you're 2 hours away from an OBGYN. So what do you get there? Does it cost you much? Is that a cost driver? Now, that's a more common day-to-day type of situation versus having specialties, subspecialties within a day's drive, an hour's drive. How do you see that in the way it impacts you as a cost driver to the system?
It's a great question, Senator Stivers. So let me approach it in a couple different ways. First, I would just say when we think about workforce, we translate that to network adequacy, and we need to meet the regulatory demands of our contracts. So it's absolutely something we think about. 150 million Americans defined by the federal government don't have access to primary care on a consistent basis. It's even worse as we think about substance abuse and behavioral health. The cost is always another conversation we had as a sidebar is we have to understand how policy, both the federal and state policy, impacts provider reimbursement. When we think about a birthing center or we think about an outpatient or inpatient stay, it's what are the mechanisms for reimbursement, and how do we educate on those? What has a prospective payment system? What has a federal match and a drawdown? How does an independent versus a provider who's related to a system, how are they reimbursed? I do think we need to recognize two things. One is that you absolutely have to have centers of excellence when you think about specialty care. The economics truly do demand that you have the ability to have those types of services within a lot of our metropolitan geographies. What our job is to figure out how we fill those gaps and how do we make sure that access still remains. From a managed care perspective, we do several things, and no, not all of them are the answers. We're still searching for the answers. Some of that's benefit design. In a lot of our Medicaid programs and Medicare programs, we ensure that the transportation is provided where it doesn't get reimbursed from a fee-for-service basis. We have access from a care coordination perspective where if a member can't get into a dentist or they can't find an OBGYN, they can call Humana. And it's our job to ensure that we find that. But I think we still need to continue to have the conversation. And it is a valid point that from a state perspective, we do have to talk about reimbursement. One thing is we do have to consider the reimbursements for our rural communities, but we have to consider it in the context of how rate setting works and how a broader program works. We can't take a dollar from a metro provider and give it to an urban provider without breaking something else. So we either have to find savings in how we coordinate care, or we have to find a different model in order to reimburse that.
Then I'm going to throw this into the mix. Anybody can jump in. AI and telemedicine. You all see any big impact coming from either one of those?
It's going to be the biggest impact in healthcare over the next 2 to 5 years. I serve on a national AI and healthcare committee, and I've been on it for, I think, 2.5 years now. We travel all over the country, and we're in Canada, in Toronto. And then my wife and I just got back from China last week and was over there looking and talking to them about AI and just a lot of subjects in healthcare. And you're going to see probably in the next 2 years that the first visit for both Medicare and Medicaid is going to be with an AI bot. There's one out, write this down, Tom MD, and go look at it. It's a primary care bot that is being pushed out. Google is behind it. The folks that did WebMD are involved in it, and it works. I mean, I still say there's got to be humans involved, but I do a whole little talk about AI. I say AI has no conscience, it has no morals, and it has no ethics. And if there's not a human component, and I as a Christian am especially concerned about artificial intelligence and where we're going with it. But the people that are building the most data centers right now and doing the most work on AI are in China, and they are getting ahead of us quickly. So I'm very concerned about AI in healthcare.
Let me just add a note on telehealth, because that was one area that we really looked at in the Healthy Moms and Healthy Babies legislation. In about half the counties in Arkansas, a pregnant woman does not have access to a provider within her own county. She has to travel outside of her county to seek health care for her pregnancy. And so the Healthy Moms, Healthy Babies Act included language in it that would improve access to telehealth. Because what studies have shown is that the compliance rate for women to seek prenatal care increases in situations in which things like transportation and distance are not burdens to them. If you think especially in terms of a rural Medicaid population, you will run into people who may not necessarily have a vehicle available to them, a reliable vehicle, who may not be able to take time off work in order to go to a provider during the week that's an hour or 2 hours away from them. And so having access to more telehealth options does allow them to be able to communicate with their obstetrician, to have questions answered, and to get that day-to-day care. Now, that doesn't necessarily solve the problem, of course, of urgent care needs or of labor and delivery. You're not going to have a provider talk you through how to deliver a baby in your living room. And with all respect to Tom MD, I've gone on WebMD my whole life, and it always tells me I'm about to die. So, we've got a little work to do, right? But in terms of ensuring that we have access to, or give access to a provider in order to get those questions answered on a day-to-day and to ensure compliance with those vital prenatal appointments, I think that we can see a lot of really good things to do with telehealth. And that also folds into what we're seeing with our behavioral health providers. Same issues with people in rural areas who need to speak to a therapist or who need to communicate with a psychiatrist about medications. Being able to do that from home improves their outcomes as well. It improves compliance with their treatment plans, and being able to access their medications, of course, ensures that especially the seriously mentally ill are more able to maintain their medication protocols, stay on their treatment plans, which keeps them from going into that pipeline into prison because they're committing crimes. In cases where you've got the severely mentally ill, if they're able to receive treatment within their communities, then we see those outcomes start to improve as well. So there are a lot of real benefits, I think, to telehealth in our states. And I'm a big proponent of trying to make it easier for beneficiaries to access telehealth, especially in areas where seeking medical help from a human being one-on-one may be more challenging.
Senator or doctor, which one do you want me to call you? Take
Either
your choice.
one.
Speak as a doctor.
I would say that before COVID, we really were not using telemedicine very much. And during COVID, we had to. And what we've learned is that some things are more amenable to telehealth than others. And I think those boundaries are being better defined now, and the technology will help us. However, I go back to what Senator Burgin said, and I did a bill this year about the use of AI in prior authorization for insurance. And it's all good to use AI, and it's a great tool for providers as well to automate and streamline the process. However, if you're going to deny somebody's medical care, a human has to review it. A clinical peer has to review it. So I think that the parameters are going to become more clear, but it's going to be a hot topic for a few years.
Well, we've opened up the can of worms here because I know you can put in 5 or 6 symptoms and get 756 diagnoses of what's wrong with you. And so, Jeb.
And you're always going to die. Yeah.
Well, and I'll go back to, and this is affecting we have 2 hospitals in our county, 147,000 people. We've not had labor and delivery in the last 2 years because we had 2 OBGYNs. One of them retired out, couldn't get another one to come. And so women have to drive, 35, 40 minutes to another county to get services. Now, the hospital we're working with them, and they say they're going to bring it back. But I've seen that happening everywhere. And consolidation in healthcare is a big concern. I'm afraid in North Carolina, we're going to end up with 3 or 4 systems, and then everybody else is just going to have to drive and get there. And I think it's happened. I've met a lot of you over the years being in the legislature and coming to all these meetings and the other meetings we all go to. We're all facing the same things, and it's harder and harder for rural hospitals to compete, and I think that's going to continue. But there's so much money being spent right now, and I don't know if we're going to have a chance to talk about involuntary commitment, but that's another thing that's blowing our system up too.
Quick thoughts on AI is what do we know and what we don't know, and how do we have a commitment to work together, to do it transparently, to do it humanely, and to do it compliantly. Working in corporate America, you know that AI is absolutely going to change the game for everyone. It means costs will come down as we think about administrative costs. I think our encounters will improve, our ability to communicate reporting will improve. If we think about a provider who doesn't have access to AI and the resources, they will look like the quality of their systems are poorer and their outcomes are poorer. If from a cost structure, if you have a provider who's not using AI and you have a provider who is, if we can't help them and support them in that journey, then they may not survive, and you're going to see more and more consolidation. So how do we as a community, as states, ensure that our lessons learned from AI are spread broadly and that we're able to understand those impacts? And I also say it's going to advance as we think about cost. If we think about the cost in Medicaid, the vast majority of that cost is pharmacy costs. If we're applying AI technology to advance care, we are going to see increasing cost structures around our specialty care and our pharmacy costs. And we need to make sure that those dollars are being distributed in a way that support the outcomes of our members and patients, and that they support the programs that exist within Medicaid.
Okay, I'm gonna go back to one last thing because I got the 1 minute notice, and then we're going to open it up to the audience for questions. Senator Burgin, you talked about education and recruitment and how you don't have certain people. How much do we have to place responsibility on our educators, the people who are producing the radiology technicians, the nurses, the doctors, be it an MD or an OD, to get into these rural areas or underserved areas to recruit or start programs? Because one of my universities just brought to me, let's do a dual credited program for high school students that they would actually have an associate's in nursing when they graduate from high school at age 18 or 19. How much do we need to be pushing those educational institutions? throw it open to anybody.
We've got to do that. We do that through our community colleges. Almost all the counties now have started an early college program and a dual program where you can actually be in high school, take community college credit. A lot of kids are going into 4-year now. They already have their first 2 years. But other countries are doing it completely different. If you're become a doctor in China or India or any of those, the system is completely different. The costs are different. And I think education costs, a lot of us have talked about this, have just gotten completely out of hand. And I've proposed an idea where we actually do the first 2 years of college that we do at the community college level, and encourages, saves parents tons of money, and then we could turn our colleges into the last 2 years and then graduate programs. I've also proposed an idea. I think we need to be looking at statewide year-round schools. We spend billions of dollars on new school construction, and it's proven fact kids lose a lot of knowledge over the summers. There's a lot of things we need to do in education to get us ready, and some of the training and stuff I think could be truncated and overlapped.
The other panelists about pushing our educational institutions to come up with ideas on how we fill those unserved, underserved areas.
Well, you've got a great program in Kentucky. At the NCSL meeting a couple years ago, there was a whole section on a mobile unit that travels around, and it's got different age-appropriate activities for kids, starting with elementary school and going up to high school, where they can learn about being a healthcare professional and stimulating interest in being a medical professional. I think we should replicate that in other states.
And in Arkansas, and I touched on this earlier, Arkansas does have a program in which if a provider will agree to locate their clinic in a rural area that's identified as a specific area of need, that will reimburse them, I think, about $80,000 of their costs in order to get started up and establish their practice there. So we do have programs like that. One thing, kind of going back to this idea of all of these being, systemic issues, is that even if we are able to increase our output and retention of physicians, we do still have a workforce problem, not only with nurses, but also with the CRNAs, with the assistants, and with the QBHPs in the mental health area, and all of these other healthcare adjacent or healthcare supporting areas. And part of the real struggle with that, I'm a healthcare attorney. It's my other job. I guess this is my hobby. I don't know. But one of the problems that my clients run into often is the fact that these positions they're hourly positions, they're hard work. And they may be able to pay them $20 or $25 an hour, which is fine, except for that same person can go down the street to the new Buc-ee's that's opening and get paid that same amount and not have to work as hard as they do in healthcare. And often when they're competing with some of these corporate employers, those larger corporate employers can provide better benefits, better options for promotion, and things that these healthcare providers just can't. And so this kind of goes back to this idea of how we reimburse providers for the services that they're providing, and how we look at their workforce, and how we try to recruit and retain workforce beyond just the physicians and the nurses, because there are a lot of other healthcare providers that we need in order to make these systems work. And we really need to be, from the middle school and high school levels, encouraging kids to look not just at, I want to go to med school, but maybe there's a kid who really loves working with the elderly and wants to work as home care or in a nursing facility or assisted living facility. Maybe there are kids that really have a heart for working with kids with intellectual disabilities in a school setting, but they don't necessarily want to be a teacher or a provider. They maybe want to be an assistant. So we really need to look at how we can capture those interests early on and support those students as well in seeking the education and training that they need to be successful in those fields.
We're out of time for what we're going to do here on the panel. We're going to open it up to the audience. I believe we have several microphones located throughout the room, and I already see one. I'm going to ask that you identify yourself, your state, your position, and who you're directing the question to. So, Shelley, I'm going to start with you.
Yes, thank you. My name is Senator Shelley Funky Fromeyer. I'm from Kentucky, and I'd like to open this up to anyone who has an interest in answering, but you mentioned, Jeb, the business of healthcare. What is the potential of that intersection of lifestyle medicine so that we really start to see the wellness outcomes that we need? Kentucky, though, we have some innovation around Medicaid persistence in the use of Medicaid. We're not seeing it result in great health and wellness. So is there a potential business case for lifestyle medicine, naturopathic, at these rural hospitals that really collaborate, maybe even nutrition, maybe even more that can happen in those rural hospitals that are resulting in healthy, independent, thriving communities, not so dependent on Medicaid?
Great question. Thank you so much for the question. A couple things. First, I think there's a perception that outcomes aren't getting better in Kentucky. What I would say is that as a nation, outcomes are getting better, and the way we're judged is on the outcomes. And part of what is happening in Kentucky is economic and social. It is the existence of persistent poverty within that state. If we can't solve that, we're not going to independently solve the health care and the outcomes of Kentuckians. Partners with rural hospitals, with rural providers, absolutely, I think there's opportunities. Again, we have to figure out how that fits in the model. How we provide rewards either to the provider or to the member who's engaged in those activities. What I would say is that being transparent, we've designed a lot of great programs that reward people for doing healthy activities. But the reality is the people who engage in those programs are likely the people who are already going to be engaged with seeing their primary care physician, with seeing their special being adherent to their medications. We have to find ways to engage in those people who would not typically go and see that provider. And that is ultimately, if we can solve that, I think we will see better outcomes.
So I'm Delegate Jessica Anderson from Virginia. And my question, I've had a lot of conversations. I'm a former Medicaid recipient, so I was really excited to come to this platform. That's part of kind of what I ran on. But my question to you all is, obviously, we don't 100% know what the rollouts look like for the federal cuts that are coming for Medicaid specifically in January. But we do know that it's going to implement some impacts on individual states, especially in the South. And one of my concerns is we already have a pretty significant gap with healthcare coverage, which I think some of you've talked about a little bit today. And a lot of states don't have the opportunity to supplement their Medicaid coverage to effectively make the difference between the poverty federal level, which I think many of us think is in my opinion, very outdated and is not meeting the actual marker of where we are society-wise, versus ALICE, which is a more, realistic perception, meaning that the poverty rates we're seeing are even worse than what they really are on paper. What conversations are you having in the legislative body to address that existing gap on top of the fact of federal cuts coming? I know in Virginia, we have an automated program, which I was a part of. Every year, your taxes were immediately pulled to see if you still qualify for Medicaid and EBT SNAP. If you did, you were automatically re-enrolled, you were sent a paperwork. There was nothing you had to do as an individual. Now we have policy that we know without a doubt is going to be every 6 months you have to prove employment or some type of income verification. That is a pretty significant shift for states like mine and probably other states in the South. There's a very uninformed populace that is still going to qualify and not knowing the changes and going to go swipe get their Medicaid card and go, oh, you don't have health insurance anymore. So what conversations are you having about, one, informing the populace, but two, closing the gap on what we're about to experience on top of what already exists?
We're having the conversations because each county has to do that. And so all of them are reaching out to their elected officials saying, are you going to, like my county, they said, we need 6 more people, Jim. If we're going to do this every 6 months, we're going to need more people. We need this much more money. And so that's what we're all faced with. But we've got to rethink Medicaid. I think we set it up wrong to begin with. We don't have a plan to get people off. I've been talking to the folks in the White House and Washington about letting me use Medicaid dollars to pay for people to go to community college, pay for childcare while they're there, and then get them in a job. We need to have programs to get people off of government programs instead of just adding more and more people to those. And I have a saying that, thank you. I have a saying, we don't need safety nets, we need trampolines for people. We need people to be able to take care of themselves. I think, again, I'll go back to, as a Christian, I believe that people are happy if they're working, taking care of themselves and taking care of their families. And I think we're depriving people of some wonderful opportunities for employment. And I don't mean having jobs that they are still qualified for for government programs. I mean a fulfilling, well-paying job that they can take care of themselves and their families.
I'm sorry. I was just going to add one thing. I think we've got to streamline the eligibility process, and we've got to use technology to do it, because the paperwork for reporting the 20 hours a week right now is not user-friendly in our state. And we meet for 3 months every year, and our committees don't really meet in the interim unless it's a study committee. And so those of us who are highly involved with healthcare are working with the agencies, the Department of Community Health and people like that, to be sure that they're addressing that and that they'll be ready when these things change.
And I appreciate the question. I was reading an article in our local paper this morning that estimates that Arkansas is going to lose about $250 million from the cuts coming in January. And I think that there are to our Medicaid program specifically. So I think that there are a few things that we need to kind of keep in mind and balance on that. I mean, one, it was touched on earlier, we are going to get this rural healthcare transformation money, which is going to be one-time money for 5 years, $200 million for the next 5 years. But then after that, it stops. The cuts will be permanent. So we need to be really strategic and smart about how we invest those funds from this rural transformation. When we're talking about shoring up our rural hospitals, making sure that our workforce is ready, but also making sure that people are aware of the benefits and the care that are available to them. And there's been a little bit of talk about the administrative burdens and costs, not only on the system, but on the beneficiaries. And I think that your story bears that out in terms of how, people were automatically renewed from their taxes. And we see that Arkansas didn't expand the postpartum coverage for 12 months postpartum for women who just had a baby. And so that requires a new mom at 60 days to go and have to provide documentation and paperwork in order to try to patchwork together coverage to get her through that 12 months. Well, at 60 days postpartum I've got 4 kids. I mean, after my 4th one, I thought I could maybe be a Dallas Cowboy cheerleader because I'd been watching that TV while trying to breastfeed for weeks and I wasn't sleeping. I could have never filled out paperwork to try to figure out how to continue my health care. So we need to look at the cost benefit analysis on whether or not forcing people to continue to do paperwork on sort of an ad hoc basis at random times and the cost associated with it, even from a processing perspective. You've got to have people to review the paperwork and file the paperwork and make decisions about it, whether that cost makes sense because there are real dollars being spent on engaging in that process versus the effect that it has on the beneficiaries and the people that we are losing who are eligible for and entitled to Medicaid benefits because they don't have access to internet. They didn't know that they were required. There was a new requirement to do this reporting or this application and so on and so forth. And, in Arkansas, we did work requirements in 2018. And so we have some data that kind of bears out the effect on the system. In 2018, we rolled out work requirements, and the stated goal then, as it is now, was to try to encourage more people to come into the workforce. What we saw was that I think about 18 to 20,000 Medicaid beneficiaries were dropped off the rolls. The majority of the people dropped off, interestingly enough, didn't have access to internet. And that was a big barrier when they were supposed to be doing their reporting on whether they had a job or whether they qualified for an exception. And they had to do it through a portal. So we dropped them off the rolls, and then we look at what the data shows us about workforce participation. Didn't change. No change. So again, we need to look at, what our stated goals are. If the stated goal is to go through and check eligibility for people, that's one thing. If the stated goal is just to create a burden and an administrative burden to keep people off the rolls, that's another thing. But there is a cost to that, especially when we know that every Medicaid dollar that we spend has an ROI of about $8 to $9 back into the state because of the fact we're not doing uncompensated care and we don't have a bunch of people showing up in our ERs and putting strain on our rural hospitals.
I hate to do this, but we are at our time. And what I am going to say is I have like 6 more questions I could ask. I hate to stop this, but we are at the 1:30 time marker. So for 2 people, I'm going to hope some of our panel stick around. We appreciate this opportunity. There are so many questions circulating around Medicaid, and not just Medicaid, healthcare and everything that influences healthcare. But I want to say thank you all to the panel. Appreciate the opportunities that we've had to discuss Medicaid and healthcare here today. To the audience, thank you for the participation. We could go on. Don't know if you're all going to stick around, but I'm sure throughout the week you all will be available for further conversations. And to the group, welcome to Kentucky. Thank you for being here. And let's give our panelists a good round of applause.
Our thanks to Kentucky Senate President Robert Stivers for moderating this Medicaid discussion, and to Senator Jim Burgin of North Carolina, Senator Kay Kirkpatrick of Georgia, Representative Ashley Hudson of Arkansas, and Jeb Duke of Humana for sharing their perspectives. As you've heard, there is no simple answer when it comes to Medicaid. States across the South are balancing fiscal responsibilities with the need to expand access to care, strengthen the healthcare workforce, support rural communities, and prepare for the rapid changes in technology and federal policy. While each state's approach may differ, the challenges and the opportunities are remarkably similar. That's exactly why conversations like this matter. The Southern Legislative Conference exists to bring policymakers together to learn from one another and exchange ideas that can improve the lives of the people they serve. Thanks for listening to Real State. Subscribe wherever you get your podcasts and visit csgsouth.org for more resources like these. Until next time, I'm Lindsay Gray. Let's keep it real.
Thank you for joining us today on Real State, where we keep it real about what really matters.